Hello YouTubers, this is Dr. Kulla, Synergy Wellness in New York City. We have Steven here who has allowed us to shoot a video here. We're going to go over his case with you. His case is not uncommon, it's very common. He has a herniated disc in his lower back which creates numbness. Well, why don't you tell everybody what's going on with you? What kind of symptoms you have?
Sure. I get some numbness and tingling down my left leg into my left foot. The left side is really the goofy side. Things act up over there. Sometimes I get a little numbness and tingling in my right foot as well, but that's less common.
Mm-hmm. Yeah, so he has tingling in both legs, both left and right. Obviously, as he said, it's a little bit worse in the left. Goes all the way down to the top of the ankle. So for those of you watching this, if you have leg pain or numbness or tingling shooting down the leg, it doesn't have to be with back pain. You most likely have a disc herniation. And he has mild canal stenosis from congenital, from when he was born. Yeah. Right, congenital mild canal stenosis at L4, L5. So we've been treating that with Cox Flexion distraction technique and spinal decompression. So we just put him on spinal decompression. Today is visit number about 12 visits, 12 or 13 visits over 4 weeks. How are you doing right now?
I'm better than I was.
Okay. How's the leg numbness? Are you still having that, or?
It was, yeah, it's minor now. It's much less common. It's not a constant feeling that the numbness is trying to creep up on me anymore. It used to be more continual and constant.
Okay.
And now it's really backed off. Now it's much less frequent. It's more situational. It's It's more manageable. Yeah.
Okay, and the fact that he's 6'4".
True.
Doesn't help either. He's really tall. As I say this as I'm ducking down to get into the camera here. He's sitting, so but he's a lot taller than me. I'm 6'1". So that makes it difficult because you have to do a lot of bending to reach things, which could be stressful on the back for tall people. So let's have you take your glasses off and we'll show everybody how we do Cox Flexion distraction technique. So as I said, everybody, we already did spinal decompression for him. Now we're going to go to, we're going to use the Cox 8 table here and do some flexion distraction. So I've already taken him through protocol 1, and so we're going to just strap him in right away. When we get a new patient that we've never done this with, we start them out without the legs strapped in, just to tolerance test the patient and make sure it's not going to make things worse and set them off. So this table here has a tiller here. I'm able to press this button and it increases the tension. You'll see how it brings the table up automatically, with power. So we're just going to place hand placement above L1 to start with, and just open up the foramina and the spinal canal here with some Cox Flexion distraction technique. We've done many videos on this. If you have a disc herniation or spinal stenosis or sciatica, this is the gold standard treatment. It's called Cox Flexion distraction technique. It's a part osteopathic, part chiropractic technique. It was originated by Dr. Cox, who was an osteopath, and then his son, Dr. James Cox, further perfected it. And Dr. James Cox, his son, is a chiropractor. So an interesting family at that. And now Dr. James Cox, the chiropractor, is, I'm going to guess, in his 80s now and still going strong. So a lot of chiropractors have this table, but they're not necessarily certified in it. So they may have the equipment and the table, but it's really important to know what you're doing. Now, most people will get better with the technique, whether they're certified or not, but in some of those more complicated or severe cases, Having that certification goes a long way. So right now my hand placement is lower. I'm now down by just above L4. And I'm not going to go any lower than that. I'm definitely not going to place my hand on L5 or L4. Just above it at L3. And again, that's the lowest we're going to go, because if we go lower than that, he's not going to get off the table feeling well. And we don't want that. Right? Okay. So typically we get about 4 to 6, 40 to 60% improvement in symptoms within 4 weeks to 5 weeks. Now, in some cases, some more severe cases, it may take a little bit more than 5 weeks. Naturally, a disc takes about 3 months to heal and repair itself. So, on average, anybody that has a disc herniation or pain from a disc herniation, they're going to take 3 months to heal. That doesn't mean they're going to be in pain for 3 months. His pain is reduced. How much would you say? Is it 50% less, more?
Yeah. Well, for the actual pain in my lower back, my pain has really improved. I'd say the pain has improved more than 50%.
Okay.
I'd probably say the tingling and numbness has improved more than 50% too.
Okay, so that's what we're looking for. That's the expectation. Our expectation with this technique is to improve all his symptoms by a minimum of 50% in 4 to 5 weeks. And we're right on track for that. So at the end of October here, at the end of this month, he should have complete resolution or close to complete resolution of his condition. So thank you guys for tuning in. If you have any questions, or if you want to watch the rest, you know what? We're going to watch the rest of this adjustment. We're going to keep this camera rolling, and you guys can watch the rest of it, okay? So, Stephen, I'm going to have you lay on your left side. Okay. And take a deep breath in and blow all the way out and relax here. Good. And the other side up. Now this adjustment here on this side, you guys won't be able to see it, but we're going to be tractioning his sacrum down and opening up that L4, L5, S1 disc space very gently. Okay, now lay on your stomach. Then another thing we want to do here with Stephen is check his psoas muscle. Because he's so tall, he has to bend to reach things. And the hip flexor in our back that's connected to our back is the psoas muscle. And the only way to get to it is through the stomach, not through the back. So we're going to release that because I'm sure his psoas muscle is really tight. Again, that psoas muscle attaches to T12, L1, L2, L3, L4, and L5 vertebra on the side of the vertebra, runs down through the groin and attaches on the inside of the hip. And it's a hip flexor and a lower back lateral and forward flexor. Okay? So go ahead, take a deep breath in and blow all the way out. And on your back. So I'm going to show you guys how we check for psoas tightness. This is not the only way to check. This is only good for people that don't have major shoulder issues. And yeah, his left one is tight. So I can tell by elongating his arms over his head if one hand or one arm is shorter than the other. When I put them together at the midline, at his nose, right at the sternum, and at the umbilicus, then I could tell one arm is shorter. I know 99% of the time that psoas on that side is tighter. There are other ways to test the psoas, and I could show you another way. So another way to test Stephen's psoas would be to do a muscle test, okay? So what we want to do is we want to take your foot here, and then I'm going to have you turn your toe out, and I'm going to push down this way. And I want you to resist me. Ready? 1, 2, 3, resist. Okay. And 1, 2, 3, resist. Okay, relax. Now what that does more than telling me what psoas is tight, that tells me which psoas is weak. Okay, so I could either inhibit that other side, stronger side, or release the inhibited side and make that stronger. It just depends on what's going on with the patient. So right now we're just going to release this tight psoas here on the left because both of them tested normal strength, so he's okay there. You feel that in your lower back? Mm-hmm. Yeah. And if the patient is overweight, you know, obviously you have to push through some more belly fat. But what I'm doing is I'm getting in between, halfway in between the belly button. Here, I'll show you. Halfway in between his belly button and the ASIS, or the front of the hip. So that bony hip point you have here in the front, that between that and your belly button, halfway in between. And that's the point of the psoas muscle. It obviously runs up the spine higher, but that's the best point to reach it at and to release it from. And it's not comfortable for most people. Is it? Is it comfortable?
Not super comfortable, not super uncomfortable.
Okay.
Well,
most people hate it.
Well, I'll take it.
Especially if it makes you feel better, right?
That's right. Absolutely.
Okay, deep breathing in and out. So in the beginning, when we first saw Stephen, he had a hard time putting shoes and socks on, right?
A little bit.
Yeah. Are you able to do that now?
Absolutely.
Okay. Okay, let's check the arms. There we go, and it's balanced. And I know you guys can't see from there. You're going to have to trust me on this. It's a great psoas test. As long as the person doesn't have major shoulder injuries or has had shoulder surgery. Okay, and relax yourself here, Stephen. That adjusted. You probably heard that, guys, just on the setup, right? All I had to do was kind of turn his head and it corrected itself. So his neck was really out of alignment. Also right here. Relax yourself here, sir. How you doing?
Good. Oh, good.
All right, you're all set. Come up from your side or from the side lying position.
Right.
There you go. See that, folks? That's the right way to get up, the way he did it. Thanks for letting us show everybody what you're going through. And if you guys have any questions or comments, make sure to comment below. Thanks for tuning in.
Thanks, Dr. Kulla.
You're welcome.